Good morning. On behalf of Claudia Cohen and myself, Diane Wilson, as the committee co-chairs of the Advisory Committee on Blood and Tissue Safety and Availability, welcome to the 59th meeting of the ACBTSA. Welcome to our newest committee members, and thank you all for taking the time out of your busy schedules to participate both virtually and in person at this meeting. A few housekeeping items before we start. There's a QR code listed on the screen above, and you can take a picture of that, and it will give you the bios and the agendas for our meeting today and tomorrow. For those of you in person, the bathrooms are outside to the right on this floor. Water is in the back of the room. And I would ask that all of you put your phones on silence for the meeting, please. Now it is my honor to introduce the Assistant Secretary for Health, Admiral Rachel L. Levine, who will provide us with opening remarks.
Good morning. It is an honor to welcome our ACBTSA members, all of the speakers, and those across the nation watching online to the 59th meeting of the Advisory Committee on Blood and Tissue Safety and Availability. First, I would like to start out by thanking the committee members for your time and your dedication to the committee and to this important topic that you will be discussing. I sincerely appreciate you providing your knowledge and your expertise. Your expertise is invaluable to me and to HHS as we strive to build a safer and healthier nation. I want to extend my thanks to Ms. Kay Hayes, the Director of the Office of Infectious Disease and HIV/AIDS Policy, and to Mr. Jim Berger and the team for all that they have been doing to push this important work forward. Thank you to the chairs of this committee, Dr. Claudia Cohen and Ms. Diane Wilson, for your leadership and guidance. And thank you to the leadership of the Tissue Tracking and Traceability Working Groups, Dr. Tim Pruitt and Mr. Scott Brubaker. I am grateful for all that you do for the committee. Each year, millions of people in the United States have their lives transformed by the generosity of tissue donors. Approximately 2.5 million life-saving tissue transplants are performed annually. Tissue transplantation benefits patients in various medical circumstances, including serious and life-threatening situations. Just one tissue donor can help more than 75 people. Even with the safeguards that exist through donor screening, testing for certain infectious diseases, and processing procedures, there is still some degree of risk. As the Assistant Secretary for Health, I was alerted to this topic after the 2021 transmission of Mycobacterium tuberculosis. I asked my office to look for solutions to improve tissue safety and biovigilance. Now, more than ever, there is need for improved tracking and reporting systems. Timely identification of tissue-derived infections is crucial. With the outbreaks that the United States has seen in recent years, it is important that we take steps to address the tissue traceability issue that exists between donors and recipients, in part due to the variance between facilities. Americans deserve to know that any tissue product used during a medical procedure is safe. They deserve to know that every effort has been made to ensure that tissue will not transmit disease. Your discussions and deliberations will help us improve tissue biovigilance and tracking and address several other key questions. The challenges of tissue-transmitted infections and traceability, federal regulatory oversight that applies to tissue tracking and traceability, and how tissue establishments conduct product tracking. The information that you hear from speakers on traceability and reporting requirements in the blood and organ industries will help shape and inform your discussions. The discussions that you will engage in today and tomorrow will focus on the collaborative efforts needed to enhance tissue biovigilance. Working together, we can create a system that is safe and effective. I look forward to reviewing the recommendations that come out of this meeting. I appreciate your dedication and commitment to advancing tissue biovigilance and safety across the United States. Thank you again for your time and effort dedicated to this important topic.
Well, thank you, Admiral Levine, for those remarks. And I will say wholeheartedly, she takes us to task. And I want to thank Jim Berger. He is our senior advisor in this space, our designated federal official. And I think he must brief, and we brief Admiral Levine at least 4 times a week. And that is at the least. She is here with us in spirit as we move on today. So I have the fun part of the job here. I want to say we're going to move forward in swearing in ceremony of new members. I'm going to ask that they come forward with Susan Galel, Daniela Hermelin, Michelle Kim, Yvette Miller, and Stephanie Pouch. Please come forward and stand over here for me. And we have 2 new members who are going to be joining us virtually. That's Sarah Barnyard and Megan Delaney. So they are going to be, I believe, a spotlight. All right, so I'm going to come around here. Megan and Sarah, please raise your right hand. Perfect. Thank you so much. All right. I do solemnly swear and state your name. That I will support and defend the Constitution of the United States against all enemies, foreign and domestic. That I will bear true faith and allegiance to the same. That I take this obligation freely, without any mental reservation or purpose of evasion. And that I will well and faithfully discharge the duties of the office on which I'm about to enter. So help me God. Congratulations, congratulations. All right, so congratulations and welcome to our to the committee. We look forward to working with you all over the next 2 days, couple of days, and the duration of your terms. So I want to say congratulations. Before we move on and I pass the torch here, I want to say that I would be remiss if I did not mention that we have a number of members that today is their last meeting. Their terms are coming to an end. And they've been incredible members of ACBTSA. I have certificates of appreciation for Eliza Gordon, Jed Gorlin, Paul Ness, Lynn Yule, Glenn Ramsey, Eric Santiago Justiano, and Michelle Kameka. So these are our outgoing members, and we will present you your certificates later in the meeting. I just want to thank you for sharing your expertise, your knowledge, your time, your commitment. And just because your term has expired doesn't mean you are not still a critical partner in the work that we do. So we continue to look forward We always have public comment. You know the DFO personally, so we look forward to your continued expertise as we move along. I will now pass over everything to your DFO, designated federal official, Jim Berger.
Thank you, Kay. The next responsibility is to do the roll call to ensure that we have a quorum. So with that, and since we do have new members, I think it's a great opportunity for the committee members to introduce themselves and to identify where they're from an organization. With that, I'll start with Stephanie.
Good morning, everyone. My name is Ray Goodrich. I'm a professor in the Department of Microbiology, Immunology, and Pathology at Colorado State University.
Good morning, Stacy Syme. I'm president and CEO of LifeServe Blood Center in Des Moines, Iowa. We serve Iowa, Nebraska, South Dakota, and Illinois.
Hi, I'm Susan Gallel. I'm a blood bank and transfusion medicine physician, and I'm a contract consultant to Roche Diagnostics.
I'm Jed Gorlin, Medical Director and VP at Blood Centers in 3 states, Transfusion Service Director at a trauma hospital and a children's hospital, Chief Medical Officer of America's Blood Centers, and outgoing Chair of Transfusion Transmitted Disease Committee for ABB.
Morning, everyone. I'm Daniela Hermelin, and I'm the Chief Medical Officer of Impact Life Blood Center that's located in Iowa, and we collect blood in 4 states, Missouri, Wisconsin, Iowa, and Illinois. I'm also an assistant professor of pathology at St. Louis University Hospital, where I cover both the adult hospital, children's hospital, and obstetrics hospital. Thank you so much for having me today.
I'm Glenn Ramsey. I'm at the Northwestern University School of Medicine, medical director of the blood bank at Northwestern Memorial Hospital in downtown Chicago, and also a member of the College of American Pathologists, which is part of the committee representation here today.
Hi, everyone. Good morning. I'm Josh Penrod, Senior Vice President of Global Plasma for the Plasma Protein Therapeutics Association. Basically, my role there is heading up all of the technical initiatives, anything that's not lobbying, associated with the trade association.
Hi, I'm Scott Brubaker. I'm a senior advisor in the Office of Cellular Therapy and Human Tissue at CBER at FDA.
Hi, I'm Claudia Cohn. I'm a professor of laboratory medicine and pathology at University of Minnesota, and I am the Chief Medical Officer of the AABB.
I am Diane Wilson. I am the Chief Operating Officer at Solvita Blood and Tissue Center.
Sridhar Basavaraja, Director of the CDC Office of Blood, Organ, and Other Tissue Safety.
Marilyn Levy from HRSA, Health Resource and Service Administration. My background is transplant infectious disease.
Oh.
Okay. I'm sorry. My name's Diane Corning. I'm the ex officio for CMS. I work in the clinical standards group, and we're responsible for the health and safety regulations regarding Medicare and Medicaid providers.
Good morning. I am Michelle Kamika. I am a professor in the College of Nursing and Health Sciences at Florida International University in Miami, Florida, and also patient advocate.
Good morning. I'm Dr. Yvette Marie Miller. I am a medical officer for the American Red Cross, and I oversee donor eligibility and recipient complications for Red Cross. And one of my key roles is being an advocate for patients with sickle cell disease and communities affected by sickle cell disease.
My name is Paul Ness. I am Professor Emeritus at Johns Hopkins Medical School, where I retired from recently after running the transfusion medicine program for about 40 years.
Hi, my name is Michelle Kim. I'm a patient advocate to 2 children and many years as the executive director of the Hemophilia Foundation of Southern California. My beautiful daughter, Kayla, she has received every blood product known to that's out there, including a lifetime of plasma products. Unfortunately, she passed away last March. She was unable to receive her much needed liver and kidney transplant. And at her eulogy, the first thing I did was thank anyone who had ever donated any kind of blood product of any type. It is truly a life-saving thing to do. And so it is in her honor and her memory that I am here today. And thank you so much for accepting my nomination.
I'm Dr. Lynn Ewell, Professor of Clinical Pathology, Harvard Medical School, Vice Chair of Laboratory and Transfusion Medicine at Beth Israel Deaconess Medical Center, and the outgoing AABB representative. Thank you.
Good morning. I'm Cassandra Josephson. I'm a professor of oncology, pediatrics, and pathology at Johns Hopkins University School of Medicine. I'm at Johns Hopkins All Children's Hospital down in St. Petersburg, Florida, where I am the director of the Cancer and Blood Disorder Institute, as well as the director of the Blood Bank's Transfusion and Apheresis Service. And prior to me moving there, I was at Emory for over 20 years at Children's Healthcare of Atlanta and at Emory running the blood tissue and transfusion service. So I have lots of experience in being a hospital tissue bank as well as a blood bank. And I look forward to helping on this committee. Thank you.
Good morning. I'm not on the committee. I'm a speaker. I'm Dr. Ann Etter. I'm the director of the Office of Blood Research and Review, the Center for Biologics Evaluation and Research, Food and Drug Administration.
Thank you. With that, I have some members that are online. And with that, I'll just announce your name and if you could introduce yourself. I'll start out with Sarah Barnhart.
Good morning. I regret that I am not able to be with everyone today. My name is Sarah Barnhart. I'm Associate Professor of Pathology at the University of California, Davis on the West Coast in Sacramento. I'm currently president of the medical staff here. I serve as medical director of transfusion services and cover our apheresis clinic in a rotation. And then I also serve as the hospital patient flow medical director. Thank you for having me.
Next, Elisa Gordon.
Hi, good morning. I'm Elisa Gordon, and I'm a professor at Vanderbilt University Medical Center in the Department of Surgery and Center for Biomedical Ethics. My focus is on transplant ethics. I'm a health services researcher, and I'm a former chair of the OPT and UNOS Ethics Committee. So I've been doing work in organ transplant ethics for over 25 years. I'm going to be rolling off of this committee, and I just wanted to say what a pleasure it's been, and I appreciate the opportunity to contribute to this important role. Thank you.
Next, I have Megan Delaney.
Hi, good morning. My name is Dr. Megan Delaney. I'm sorry I'm not there with you in person. I'm the incoming AABB representative. My role is I'm a professor of pathology and pediatrics at George Washington University, and I'm the chief of the Department of Pathology and Lab Medicine at Children's National Hospital in Washington, D.C., and the director of transfusion medicine as well. I'm also the incoming president for AABB, and I'm currently serving as the medical staff president at my hospital. It's a pleasure to be here. Thank you.
Next, I have Sushita Bandy.
Hi, good morning, everyone. And I'm also sorry I could not attend in person today.
My name is Dr. Suchi Pandey. I'm a clinical associate professor at the Department of Pathology at Stanford University and also the chief medical officer of Stanford Blood Center. My primary focus is providing medical oversight to the blood center, but also do cover the Stanford transfusion service as well, caring for transfusion and apheresis patients. Thank you.
Next, I have Benny Yang.
Hi, I'm Benny Jang. I am a professor and chair of the Department of Ophthalmology at the University of Pennsylvania Perelman School of Medicine in Philadelphia. I'm a cornea transplant surgeon by trade, and I'm here today representing the Eye Bank Association of America. I apologize that I can't be there in person as my dean called a meeting that I had to attend to tonight.
Thank you. With that, we do have a quorum, and I'll turn it back over to the chair.
Thank you very much, and thank you all for attending today. We are gathered here today to discuss a very important topic. In November 2022, the advisory committee voted unanimously to form a tissue biovigilance subcommittee in response to the tissue transmitted outbreaks of Mycobacterium tuberculosis and Mycoplasma hominis. These outbreaks highlighted a persistent traceability problem between donors and recipients of tissue products, which have a direct impact on patients and their safety. This subcommittee was co-chaired by Mr. Scott Brubaker at the FDA and Dr. Timothy Pruitt at the University of Minnesota. And we sincerely thank them for their leadership and hard work over the last nearly 2 years on this important issue. Today, we will hear from a diverse group of speakers from various agencies and organizations, including Center for Disease Control and Prevention, Colorado Department of Public Health and Environment, Food and Drug Administration, Organ Procurement Transplantation Network, Centers for Medicare and Medicaid Services, and American Association of Tissue Banks. These presentations will provide valuable perspectives on tissue transmitted infections, traceability challenges, and regulatory oversight. We will help guide our discussion of the Tissue Biovigilance Subcommittee recommendations, which will take place tomorrow. To begin, I would like to introduce Dr. Michael Bell, the Acting Director of the Division of Healthcare Quality Promotion at the Centers for Disease Control and Prevention, who will provide us with introductory remarks. Dr. Bell.
Thank you so much. Good morning, everybody. Thank you for letting me have a few minutes of your time. I'm very excited to be here with you for a number of reasons. My division, the Division of Healthcare Quality Promotion, focuses on patient safety across the board. That ranges from outpatient care to long-term care, nursing homes, and of course, acute care and transplant/transfusion care. The issue that you're talking about today is something that has been a perennial challenge. I would say it's been an intractable problem for the 30 years that I've been here. I am chagrined to point out that nothing has changed, right? The tuberculosis outbreak was just another example of the challenges inherent in tissues that can't be completely sterilized, that are difficult to trace, can be shared amongst multiple patients, carried around in the pockets of a surgeon. There are some really incredible systems challenges built into this topic. I am so grateful that the subcommittee was formed. It is such a wonderful moment to take a step forward. And reading the draft recommendations that were shared earlier, I was gratified to see so many pragmatic, rational steps that you have drafted. I'll just say a couple words about sort of the systems that we all work in. Many of you know this intuitively, but I'll frame it for others. And that is that there is the pre-marketing piece where there are things that need to be done appropriately to optimize the safety of tissues. That is one end of the spectrum. And then there's the post-marketing piece. And I'm going to focus a little bit on the post-marketing piece because we don't have that much control over the pre-marketing part. That's a different agency. But here at CDC, we think a lot about, well, what happens once this product arrives in the healthcare sector after it's been approved? how do we make sure that the product is appropriately labeled, tracked, managed, stored, and discarded? How do we deal with the fact that if we find the tip of an iceberg, we're able to see the rest of it? Right? This is the labeling and the traceability piece. Years and years ago, Matt Kunert, who is in the audience, pointed out that we're able to barcode and trace cereal across the country, but we can't seem to do it with tissues. And that has been a burr in our side for a very long time. I also think a lot about how we get things to really happen. And major kudos to our CMS colleagues. They have the carrot-shaped stick that is reimbursement. And thinking about how the options that you've framed out in the draft recommendations can be turned into something that can be part of how we reimburse medical care, so that facilities have a driver to ensure that it gets done every single time, is something that I'm thinking a lot about. As we move from here to the BOTSEC meeting, thinking about what it takes to move from a practical conceptual recommendation to something that can be systematized so that our national systems are able to embrace them consistently from coast to coast. That is the major challenge that we see in healthcare day in and day out. But I do think that what I saw in those draft recommendations really lend themselves to that. I'm very optimistic that this will be a watershed moment that will push us forward. Certainly, as we look at our aging population in this country, the need for routine tissue is growing daily. There are more and more pieces of other people in people's knees than ever before. And also, as we look at the extension to other care, organ transplantation that makes use of a piece of vasculature to connect a liver to a patient, right? That's tissue transplantation as well, and that makes it possible to do so much else. So I see this as such an important moment. I'm extremely gratified that you're taking this on and doing so much so quickly. We all probably feel that it's overdue, but better now than never. So with that, I will promise to do everything we can on our end to push this forward, to raise attention, and to work with our CMS colleagues to make this a reality. But it all is based on the wisdom and experience that you're bringing to bear. So thank you again. With that, I would like to turn it over to Dr. Sridhar Basavaraju, our Director of Blood, Organ, and Other Tissue Safety. Sridhar.
All right. Thanks for having me today, and thanks everyone for being here today. So our office at CDC is tasked with coordination of infectious disease transmissions through solid organ transplantation, blood transfusions, and tissue implantation as well. And today I'm going to describe investigations that CDC has conducted specifically related to infectious disease transmission through tissue implantation that have been led by my office and my predecessors at CDC, some of whom are in the room today. And through all of these investigations, we have some important lessons that have been learned that can enhance the safety of tissue implantation and also maybe inform some of your deliberations today. So first, let's frame the problem. As Mike said earlier, in the United States, current tissue tracking and safety measures are inadequate due to the lack of a standardized tracking and traceability system, where we're not able to track donors, tissues from donors to recipients. There's no requirements for adverse event reporting by consignees or end users. So these are hospitals or healthcare providers that receive tissues. And both of these collectively, we believe at CDC, result in imminent and ongoing risk of patient harm. And recently, particularly amongst recipients who receive tissue products that contain live cells. So just to give you some background, so this slide here includes notable cases of tissue transmitted infections that have been led or investigated by CDC and our public health colleagues in states. This dates back to 1979 when rabies was identified as transmitted through cornea, but the story really starts in the 1980s with the HIV epidemic. And just to give you some context of what might be possible and what we might be looking at eventually one day, This is a list of pertinent investigations of solid organ transmitted infections that CDC and our state health department colleagues have led, dating back to 1985. And as you can see, the story here also started with HIV. And there are some very notable pathogens that have emerged over the years that have been added to this list. There was lymphocytic choriomeningitis virus about 20 years ago, multiple other novel pathogens, including arboviral infections and fungal and parasitic infections as well. And just for completeness sake, transfusion transmitted infections that have been investigated by CDC. This slide just goes back to 2015. And there are some notable arboviral infections, most recently Cache Valley virus in 2021, as well as recurrent cases of bacterial contamination of platelets that we have investigated with our FDA colleagues. So as I mentioned earlier, our story of tissue safety begins in 1984. And in a report that CDC published in 1988, CDC described the first recognized case of HIV transmitted through bone allograft products. And in this report, a patient was described as having received bone graft from a living bone donor who subsequently developed AIDS and died. And the recipient, unfortunately, also developed AIDS and died. And this was the first reported case of HIV transmission by bone transplantation, and the first person who was described as having transplant-associated AIDS. And the patient was a female with progressive idiopathic scoliosis who received a bone allograft in 1984 for fusion of lateral curvature of her spine. So the story continues in 1991, and in that year, CDC published a report of a transplant cluster that occurred in 1985. And a patient who had received a bone allograft 6 years prior was diagnosed with HIV infection and had no other HIV risk factors. And subsequent investigation identified that there were 4 organ recipients of a common organ donor who all developed HIV and died. And there were a total of 58 tissues and organs that were recovered from this donor. And despite extensive public health efforts, CDC investigators at the time could not locate 6 tissue products that had been recovered from this donor who had died of HIV infection. And these could not be traced to either a recipient or otherwise located, as their disposition status was unknown. And that becomes a recurring theme over the next 30 years, in that consistently in CDC-led tissue transplant transmitted infections, all tissues from donors are often not able to be located to a recipient or end user. So the story continues in 2001, and in that year, CDC and other partners reported Clostridium sordelli infection and sepsis in a tissue allograft recipient who unfortunately died. And this resulted in a national investigation of a tissue bank called Tissue Bank A for this slide. And Tissue Bank A had processed 9 donors, and there were 14 recipients of this product. On investigation, the Clostridium contamination was deemed to be due to deficiencies in sterilization during the tissue processing methods. And despite extensive public health investigation, the actual tissue processing steps and methods were only available for 8 of 9 donors. In one donor case, CDC was unable to identify tissue processing and sterilization methods. And when attempting to determine the burden of tissue contamination and potential patient safety threats nationally, so what is the risk nationally of tissue transmitted Clostridium infection, CDC concluded that there were no reliable data on the number of specific types of tissue products distributed by all U.S. tissue banks and implanted by all healthcare providers, and therefore there could be no accurate estimate of incidence of Clostridium infection through tissue implantation. And this also becomes a recurring theme in that the denominator or overall numbers of actual tissue use in the US are not statistically quantified, and therefore there's no actual accurate risk of what the risk or incidence of tissue transmitted infections are in the United States. So the unfortunate story continued in 2004, and in that year, 3 organ recipients from a common donor died of encephalitis. and were subsequently diagnosed with rabies infection. And on further retrospective investigation by CDC and our state health department colleagues, it turned out that the organ donor had been bitten by a bat prior to death, but this exposure was not reported or recorded at the time of organ donation. And oddly, at the time, another liver transplant recipient from another donor, so a different donor, also got rabies and died. And this was truly confusing until an astute clinician discovered that the patient had received an iliac artery as part of a vascular reconstruction procedure. And that iliac artery segment was recovered from the initial donor who had the bat exposure and subsequently had rabies infection. The CDC authors at the time reported this investigation in the New England Journal of Medicine and suggested multiple measures to improve patient safety as it pertained to tissue. First was an enhanced donor screening and testing, standardized procedures to store and use donor vascular segments, and tracking the use as well as non-use of tissues with an enhanced system to detect and diagnose illness among recipients. And all of these recommendations became a recurring theme in the subsequent years. So just to summarize the experience over the initial 20-year period from 1984 to 2004, CDC concluded that tissues could not be fully and accurately traced from donors to all recipients in all instances. There were no reliable estimates available nationally for tissue collection and utilization, and there were no standardized processes which existed to track the use and non-use of tissues. And there were also no systems in place to detect and diagnose potential tissue-transmitted infection events. So some attempts were made about 20 years ago to try and solve this problem. So in 2005, CDC and our interagency partners at FDA and HRSA convened a workshop to identify measures to enhance the safety of tissues and organs. And these led to a general consensus that the following measures would likely make things safer. So the first was a unique donor ID, which linked organs and tissues recovered from a common donor. A notification algorithm, which allowed for the trace back, so from recipient to donor, and trace forward, so donor to recipient tracking of tissue products. Clear mechanisms for adverse event reporting by healthcare facilities, and better communication between organ and tissue communities, which may receive products from common donors, and stronger information dissemination and education efforts of clinicians, health professionals, and patients so that they may understand the risk of tissue-transmitted infections and also be able to better recognize adverse events. So in 2025, CDC attempted to establish a sentinel surveillance network for identifying tissue-transmitted infections. So this was called the Transplantation Transmission Sentinel Network, which was intended to serve as a platform to detect threats, facilitate communication between users, and track grafts from donors to recipients. And the ultimate goal of this was to establish a rapid communication system between tissue establishments and organ establishments, as well as healthcare facilities and public health agencies. So in 2008, a pilot was implemented, and almost 1,900 donation events were recorded, almost 900 implants were recorded, and there were no adverse events that were reported by end users. However, the system ran into some very significant challenges. The first was that there was no common donor number, which made it difficult and almost impossible to track products from a common donor across multiple healthcare facilities. There was no common adverse event recognition or notification system. There was no requirement by participants to actually recognize and report these events, and therefore notification became an extremely uphill battle, and the project ended. In 2009, our colleagues at the Office of the Assistant Secretary of Health commissioned an assessment to better identify the gaps in biovigilance in the United States. So that assessment had several important observations, and the first was that the assessment recommended a government-supported national biovigilance program, which would include blood, organ, and tissues. Second was that government and private systems should be integrated so that there was a common platform for reporting adverse events. And third, that there should be comprehensive surveillance, which included benchmarking, and that HHS develop a plan to support these three recommendations. So while this was going on, unfortunately, the story continued, and the same sort of stale challenges with accurate and rapid identification continued to emerge. So in 2011, CDC investigators began to look into a cluster of hepatitis C virus transmission via solid organs and tissues. And in this case, a donor was falsely identified as being hepatitis C negative, despite actually being hepatitis C infected. And this was due to a recording error in the laboratory. And 3 organs and 44 tissues were recovered. And these 44 tissues included 43 musculoskeletal grafts, which had been chemically treated and irradiated, as well as 1 untreated cardiopulmonary patch. And when CDC learned of the potential infectious disease transmission event, 28 non-implanted grafts were located and returned back to the tissue establishment. CDC began to contact surgeons by phone and requested patient hepatitis C antibody and nucleic acid testing. And needless to say, notification to CDC was delayed. It was very difficult to identify and contact end users or to locate patients. And in that time, in that delay time, and the cardiopulmonary patch was released for use, transplanted into a pediatric patient who ultimately developed hepatitis C. And this is a complicated timeline, but in the red font at the bottom, we see when the patch was implanted relative to when the first infected patients were identified. And at the time, CDC investigators concluded that a rapid communication system may have prevented this hepatitis C infection in this child. So from this 2011 event, similar lessons were learned as those from 1984 to 2004. And there was that chiefly was that there was a lack of tissue traceability in healthcare settings, which compromised the safety of tissue recipients. And CDC recommended multiple changes that could include a standardized tissue nomenclature and coding system, traceability using automated systems, and surveillance for adverse events. And CDC also concluded in this report published in the MMWR that until these key components were implemented, otherwise preventable tissue-transmitted infections were likely to continue to threaten patient safety. So your predecessors on the ACBTSA met in 2015 to discuss tissue safety following these outbreak events. So a number of important recommendations were made by the ACBTSA, and those are shown here on this slide. Sorry about that. So first was that the ISBT 128 system should be adopted for tracking of human tissue products, that there would be creation of a national database that would capture organ and tissue donations. There would be oversight mechanisms for healthcare settings to support traceability and tissue surveillance, and that educational efforts be directed at healthcare providers so that they could better understand the risk of tissues. These would also include patient-informed consent and activities to assure the tracking, feedback of product disposition, and patient adverse events, and that there be controls and incentives for compliance with these recommendations. None of these recommendations, however, were implemented on a national level. So let's just frame the challenge. So that our AATB colleagues report that there are 58,000 tissue donors annually, and perhaps up to 2.5 million implanted tissues. However, I will point out that these numbers are not quantified, and therefore we don't have any reliable statistical estimates. But it's reasonable to conclude that the number is in the millions. Some of these tissues are minimally processed and retain live and viable cells, which retain an infectious risk. And CDC once again has identified challenges related to these products, particularly those that involve viable cells. So we can shift our attention to those now. So in 2015, CDC and colleagues in our state health departments recognized a investigation of mycoplasma and recognized a transmission of Mycoplasma hominis through tissue transplantation. And by this time, the industry had implemented a system of implant cards. So tissue products were sent out with a card that was supposed to be filled out by end users and sent back to the manufacturers. And these cards presumably contained information on tissue use and adverse events, and were intended to serve as a tracking system for tissue product use. So briefly, when CDC was notified of a cluster of Mycoplasma hominis surgical site infections in patients in Ohio that underwent spine surgery, our state health department colleagues notified us that the common link was an amniotic tissue product, which had been recovered from a common donor. So CDC learned that 27 vials were prepared from this common donor and distributed to facilities in 7 states. And we identified Mycoplasma hominis transmission through tissue amniotic products to 2 recipients. At least 20 vials from this donor were used in 14 patients, and 4 of the 14, or 29%, developed surgical site infections, 2 of which were Mycoplasma hominis. So 2 unused vials from this donor were obtained and subjected to culture and PCR at a reference laboratory where Mycoplasma hominis was detected. And the patient isolates and unused vial isolates were genetically identical, which confirmed donor-derived disease transmission. And despite an exhaustive effort, we could not confirm disposition in 5 of 27, or 19%, of total products prepared and distributed from this common donor. So we'll go into a little bit of the details here. So this figure describes efforts made by CDC and our state health department colleagues in 7 states to track and identify all products from this donor. So the manufacturer provided us a list of products and facilities to which these products were sent. And our state health department colleagues then attempted to identify the tissue, and specifically as to whether the tissue had been used or not used within facilities that had received these products. So as you can see at the top, there were 30 products prepared from this donor. 3 were discarded and not distributed. And the health departments contacted facilities in 2 instances, and in these 2 instances, the facilities reported never receiving the product despite the manufacturer confirming shipment. And in 3 additional cases, the health department confirmed that a facility received the product, but the facility could not locate the final disposition of the product that was received. So as I mentioned earlier, there was an industry practice to send a card with a tissue product with a request for physicians to return the card to the manufacturer upon implantation. And the card was intended, as I said, to serve as a method to augment tissue tracking. So we further attempted to test the utility of implant cards in reporting adverse events back to a manufacturer, and also the utility of implant cards to confirm product disposition. So for 27 vials distributed to facilities in 7 states, an implant card was sent with each product to each healthcare facility. So 2 cards, we learned, were not returned, but we confirmed that those 2 vials were not implanted. So that would be an appropriate case of lack of returning an implant card. 17 implant cards were returned with a procedure date, facility and/or provider name and address, and patient name. So that's the second box if you're looking from the right. So 2 implant cards included only a lot number, not a serial number. So we could not confirm that a specific vial was used in those 2 cases. 2 cards were returned with a procedure date and patient name and were confirmed as implanted. And for 6 additional cards, only a facility and/or provider name were included, and there was no patient information. And despite the implant card being returned documenting implantation, we confirmed that one vial was actually discarded. And for 2 additional vials, the facility had no record of receiving the vial or using the product, but the implant card was returned anyway, regardless, documenting that the product had been implanted. So now I'm going to switch attention to a large tuberculosis transmission event via bone allograft, and this occurred in 2021. So on May 25th, 2021, the Delaware TB program notified our CDC Division of Tuberculosis Elimination colleagues about an unusual cluster of 7 cases of tuberculosis in patients who had undergone spinal surgery at a single hospital in March and April of 2021. And hospital staff had identified a single common exposure, which was implantation of a bone allograft product from a single lot. So we alerted our FDA colleagues and the manufacturer, deployed a team to Delaware. Our Delaware colleagues issued a nationwide call for additional cases via the Epidemic Exchange platform a few days later. The manufacturer issued a voluntary recall, and on June 2nd, so about a week later, the Oregon State Health Department notified CDC about another case of TB in a patient who had undergone implantation of bone allograft from the same donor lot. So, working with our FDA colleagues and the manufacturer, as well as our state health department colleagues and healthcare facilities, CDC rapidly traced product units and affected patients nationwide. So as I mentioned earlier, we learned that the suspected product lot was procured from bones recovered from a single deceased donor and was processed to include and retain live cells. So 154 units of this bone allograft were produced and distributed to 37 facilities in 20 US states. And thanks to rapid communication and collaboration, 18 unused products were sequestered and sent for mycobacterial tuberculosis testing at a reference laboratory or returned to the manufacturer. And the remaining 136 units were implanted into 113 recipients. So 105 living recipients were started on TB treatment just 8 days after the product recall, and ultimately we had learned 8 patients died, although that number actually went up subsequently. So CDC worked with state health departments to abstract medical records of all 113 identified product recipients in order to describe the frequency and severity of TB disease. And CDC and our FDA partners also reviewed donor screening and tissue processing procedures to identify potential lapses. Our colleagues at the U.S. Department of Agriculture's National Veterinary Service Laboratory performed TB PCR and culture on unused products that were from the affected lot. And in order to rule out manufacturing level contamination, they also received products from a different lot from different donors processed in the same facility over a 12-week period. CDC performed whole genome sequencing and phylogenetic analysis from the unused product and product recipients, as well as additional testing was also done. So we found very high attack rates of spinal and disseminated TB among product recipients. So 77% of recipients had microbiologic or imaging evidence of TB. 73% had evidence of TB at the surgical site. 25% had evidence of disseminated TB. And ultimately, 10 recipients died after product implantation. At least 3 of these were deemed to be caused by TB, with 2 additional deaths where TB was listed as a possible cause of death, and 5 deaths were attributed to other causes. So the donor in this case was an 80-year-old man who had several risk factors for tuberculosis, chiefly was prior residence in and frequent travel to a country that was endemic for TB. He was also on dialysis and had diabetes. And Donor screening consisted of the standard uniform donor risk assessment interview and donor eligibility form completed by the manufacturer. And on interview, as part of the donor risk assessment interview, the donor's proxy reported no known history of TB or positive skin or blood tests for TB, no known household exposures to someone with TB in the previous 12 months. The donor did have multiple TB symptoms, including cough and shortness of breath, which were attributed at the time of tissue recovery to hypervolemia from renal failure and heart failure. And the donor risk assessment interview did document a 70 to 80 pound weight loss, which is also indicative of TB, but these were attributed to dietary changes in the previous 2 years. The donor eligibility form completed by the manufacturer assessed the donor to not be at high risk for sepsis, though he was treated for broad spectrum antibiotics and had other findings that were compatible with septic shock. And the donor was subjected to standard donor testing, including hepatitis B and C, HIV, HTLV, and syphilis. So there were fortunately no organs procured from this donor. And the only tissues procured were bones, skin, fascia lata, and tendons, but only the bones were used. And the bones were processed at a single facility and manufactured into a product which contained both cortical and cancellous bone. The cortical bone was demineralized, but the cancellous bone was processed to retain live cells. And bioburden testing was followed according to industry standards, including bacterial and fungal testing, but there was no Mycobacterium tuberculosis testing that was performed. So TB was detected by our USDA colleagues by PCR and culture in all 8 tested bone allograft units that were unused and sent back from the healthcare facilities to the manufacturer. And whole genome sequencing linked the unused product isolates with those from the recipients. And there was no TB detected in bone allografts that were processed from different donors during the overlapping period in which this donor's tissues were processed in the manufacturing facility. So we thought that all recipients from this product were identified and put on treatment, but as I mentioned earlier, there's no standardized donor to recipient tissue tracking system in the United States. And the details of this will be described by Kristen Marshall later today. But briefly, in November of 2021, our Colorado State Health Department colleagues identified a case of spinal TB at a facility that we'll refer to as Facility A. And this facility cared for 2 patients who were believed to be involved in the initial national outbreak. So that facility received 2 units of the implicated lot from the manufacturer and reported implanting them into 2 patients shown here on this slide during April and May of 2021. And both of these patients were identified after notification of the initial national outbreak and started on TB treatment in June of 2021. But in November, the new patient was identified as having spinal TB at this facility. And this patient also received bone allograft from the same manufacturer, but was documented as having received tissue product from a different lot, which we'll call Lot B. So our CDC and State Health Department investigation ultimately concluded that there was an unrecognized product swap that occurred at this facility. But before we did conclude that, we launched a national traceback effort for Lot B. So this is the uninfected tissue product lot that was initially suspected to maybe be a second cluster of TB through bone allograft. And there were 122 products prepared from this donor. Unused product was again tested at the USDA and was negative for TB PCR and culture. But once again, 4% of these products, which could have transmitted TB potentially, could not be tracked to final disposition. So there's more again, unfortunately. Last year, there was another case of TB transmission through bone allograft products. And in this situation, the state notified our CDC TB colleagues of a patient who underwent spinal fusion surgery in May of 2023 and developed TB meningitis. And the states notified us that this patient underwent spinal fusion surgery, was a woman in her 50s with no TB risk factors who developed TB symptoms 5 weeks post-surgery, was found to be NAT positive for TB, unfortunately, ultimately died, and multiple specimens at autopsy were identified as having being ASB positive as well as NAT positive for TB. And this patient received a bone allograft product that was referred to as ViBone. So this ViBone product was produced from a different donor, different product, and a different lot from the 2021 outbreak, but had the same manufacturer. And the bone allograft product again included cancellous and cortical bone particles. The cortical bone was demineralized, but the cancellous bone retained preserved cells. And this was intended to be used in spinal fusion surgeries, so that was the ViBone product, as well as dental procedures, that's called the AlloOs product. And a few days later, CDC was notified of a second patient in a different state who also developed TB post lumbar laminectomy. So this was a woman in her 50s with immunosuppressing conditions, but no compelling TB exposure, who had a wound infection from which ultimately TB was identified by AFB and nucleic acid testing. And we rapidly confirmed that both patients received product from the same tissue donor in the same lot. But by this time, the manufacturer had voluntarily implemented TB PCR testing of products prior to distribution. So this product was actually tested for TB by nucleic acid testing and had tested negative and was therefore distributed. So CDC once again embarked on a national effort to try and identify patients and quarantine any unused products. So we learned that there were 114 units of bone allograft products, of which 64 were not distributed. Some of those were sent for additional testing to our USDA partners. 50 units were distributed across 7 states, and 49 of them were implanted into 36 recipients. So of these 36 recipients, 30 underwent spinal surgeries and 6 underwent dental procedures. 27 of them tested positive for TB infection, and 5 had laboratory confirmed evidence of TB, and 2 patients died from TB disease. The donor, once again, had symptoms consistent with tuberculosis and evidence of sepsis. And interestingly, our USDA partners identified TB after a 40-day culture period from only 2 of the 5 unused products. And so these were culture positive despite being nucleic acid test negative when done by the manufacturer. So just to summarize, over a 30-year period, CDC investigations have identified multiple challenges to tracking tissues in outbreak investigations. So these are summarized here and include the inability to confirm disposition of tissues, not being able to identify or locate recipients for testing, incomplete record keeping on tissue processing, delayed communication when a potential transmission event has been identified, which could lead to preventable additional infections, poor tracking within facilities, where either products cannot be located or are inadvertently swapped, and no mechanisms in place to prevent such errors. So we are, from time to time, asked if the organ transplant transmitted infection system operated by the OPTN could serve as a warning system for tissue safety. And in our experience at CDC, this is not possible. So if you direct your attention just to the first 2 bars only, and these are solid organ transplant transmitted infections referred to CDC by the OPTN. And over a 10-year period, only about 35% of donors implicated, so these are solid organ donors, implicated in potential disease transmission events reported to CDC by the OPTN, were also tissue donors. And there were a higher proportion, about 79%, who were vessel donors. So just to summarize our lessons learned at CDC, basic data related to tissue safety, for example, how much tissue is actually used in the United States and by who, are lacking. And as a result of that, we cannot identify risk without a denominator. So we don't know what the denominator of tissue use is in the United States. So although traceability is not an issue with, I'm sorry, just to go back to that first point, that's not the case with blood or organs. So the OPTN captures very reliable, accurate, up-to-date information on organ utilization in the US. And CDC and our OASH partners conduct a large national survey, which every other year, which precisely estimates how much blood products are used in the United States. So the second lesson learned is that traceability is not an issue with medical products of human origin, including solid organs or blood, as Ann Eder and Stephanie Pouch will describe later today. In contrast, there's no standardized donor-recipient tracking system for tissues in the US, and this problem is not limited to Mycobacterium tuberculosis. There are some efforts underway to mitigate the risk of TB through tissue transplantation, but these won't solve the larger traceability problems. When an infectious disease transmission does occur via tissues, CDC cannot reliably trace 100% of tissue products from donors to recipients or recipients to donors in all situations. And therefore, the end result of that is that patients who might receive contaminated products may not be identified or receive life-saving interventions. There are also no requirements for adverse event reporting or monitoring of patients or reporting of potential disease transmission events by end users. So these are hospitals or physicians. So we think that tissue transmitted infections are not only likely to be underreported, but also underrecognized. And we've also learned over the years that patients and even their providers are often unaware of the risk that tissues transmitting infections. And there's no required informed consent of patients who receive tissue products of human origin, unlike informed consent requirements for patients who receive blood transfusions or solid organ transplants. So none of these problems that I've discussed today are new or newly identified. In fact, they've all been previously discussed at the ACBTSA back in 2015, but that resulted in no coordinated federal action subsequent to those meeting recommendations being disseminated. And the end result of that is that there's an imminent and ongoing risk of patient harm. And in recent years, that's particularly among individuals who have received products that are processed to retain live cells. And just a personal plug, we can't keep letting this happen. This is our chance to actually do something this time. And CDC is planning some tissue safety focused efforts. For example, we're considering a survey of tissue collection and use, and also looking into partnership and communication efforts. So I'd like to thank in particular my staff members in the Office of Blood Organ and Other Tissue Safety, Ian Krachulik, Pallaviana Mbotla, Kelsey McDavid, and Isabel Griffin, as well as my predecessor, Matt Kunart, for helping me put together these slides. Thank you. So, Jim, should we move on to Scott Brubaker, or should I take questions?
We're ahead of schedule, so you can certainly take questions if
Oh,
you
okay.
like.
Okay. Yes.
Well, it was a amazing talk. And I lived through a lot of this and have tried to help over the years. But I want to say the one thing that wasn't mentioned here, which is really important, is these are the ones that were identified and that you could go trace. But we were part of the big scandal that went on with the funeral home. I can't remember the name of the whole thing, but it's when the Joint Commission got involved, like in the late 2000s. And we had to actually, call all of these parents who potentially may have gotten contaminated products from all of these donors who weren't really eligible donors. which calls into question all these people who've been who donated, and somebody actually asked them. This was falsification of donation records, and we had to, you know, talk to all of these parents about coming in for testing, which, because we didn't know whether what they received was contaminated or not. Was it tested? It was all falsified. Nobody ended up having any transmission, but this brings about that children are very much in play here, right? All these spinal fusions, all these things. I know there were a lot of adults that got stuff, but a lot of children receive tissue, a lot. And a lot of it, more and more, is bone, and it's usually bone that is not irradiated, not treated. And so they're getting fresh cells, and skin is another thing. And so I just put a plea in that, you know, these things can lay dormant for a while, and then they become immunocompromised for whatever reason, or they may not show until later on. And so I just really implore us to do something, because I've watched and worked with Matt and everybody over all these years, and we are still in the same place. Thank you.
I just want to echo the comments. Excellent presentation and excellent overview. I just had a couple of comments and a question, really. As you mentioned, there's a 30-year history now that disease transmission from these products can occur. It's also known that each time where this has occurred, the sources and causes have been identified, and they've been pretty consistent, whether it's issues related to tracking methods or treatment methods not being effective, et cetera, and sources and causes that have exacerbated the problem. Some attempts have been made to try to resolve those issues. They've not been successful. So I completely agree with your last statement. We can't let this continue. My question is not looking back, but using the information and experience to look forward, asking the question, why is this time going to be different? Because there has to be a reason or a fundamental set of reasons why the changes haven't succeeded previously. So what have we learned from those experiences to prevent what I am tempted to call, almost in some cases, a comedy of errors, but it's not a comedy. It's far from being comic. I'll call it a tragedy of errors. What are we going to do to prevent this tragedy of errors from continuing to propagate, so that we're not going to be here 10 years from now looking back on a new set of cases and saying, well, this is what we learned and it's consistent, but yet nothing has been done.
So I mean, I think that Tim and Scott have put a lot of thought into that over the last year and a half. So I feel a little bit more optimistic this time around. And I was actually here in 2015 as well, when the initial discussions. So I think that this time the recommendations that you're going to deliberate, I think, are realistic. And I think that the experience hopefully will spark some action, unlike last time.
Thank you for that presentation. Coming in from the outside was extremely eye-opening and quite shocking. It's a terrible thing for me to say in a room full of doctors, but I am a lawyer by training. so sorry, I don't practice anymore. But I think a lot of the stories that you shared seem to have some root in alleged negligence. And so I guess I'm just wondering, what are the consequences for or penalties for these kind of actions? You mentioned incorrect lab reporting resulting in multiple deaths, an unqualified donor that was clearly not vetted properly. Are there any sort of actions that are not left to private court system by the patients, because
But we have a very strong regulatory partner in FDA. So, yeah, in all of these investigations, I think FDA has taken some pretty stern actions. I mean, I don't know if Scott wants to get into that a little bit.
Yeah, I think in my talk, I'll talk a little bit
Yeah.
about the investigations that have occurred and what's happened
Right.
subsequently. But, the liability issue, we don't really hear about those, what happens later. But, associate, and I should say, companies are sued. Sure, but that doesn't really make them. So we don't really know about that. But that's a good point.
what are the deterrents?
They do change their name. We've noticed that happened, yeah.
Yeah.
Blood is different, but there, in the regulations, there are penalties for not following the regulations. And then, as Scott said, the lawsuits that are settled, of course, never come to light. But for blood, there are penalties if blood centers don't do.
I think Dr. Gorlin had a question.
Yeah, I'm intrigued by the transmission despite the NAT testing. Are there any insights? I'm pretty sure that tissue folks don't do pooled testing. So what went wrong in that testing if you could actually culture it out of 2 out of 5?
I mean, I think it's theoretical, but one thought is that there was very low burden of TB. It was perhaps heterogeneously distributed throughout the tissue product. I think some of these tissue products have inhibitors. So, yes, Susan.
Yeah, I just wanted to make some clarification about the nature of donor testing. So testing for certain diseases that are known to be found in circulating blood, like HIV, that testing is standardized and is performed on circulating, blood obtained from blood vessels. But most of what you've talked about, you referred to as bioburden testing, which is really testing of tissues. And contamination of tissues can occur either in the person before they died. It can occur during the removal of the tissues, or it can be introduced during the processing of tissues. And I think that's kind of that's a huge challenge as to what to test for. You can't test for everything. And I think one big challenge is, what do you test? That's sort of the issue that Jed's bringing up. There may be a larger concentration of lung tissue. Only test the final bone product. You may not have enough, high enough concentration of the bug in question to detect it. So what tissue should you test? And, laboratories can't validate every single strange tissue or product type. And so the validation, I think that's something that may come up later in the discussion. How do you validate the tests that are used on tissue? What do you test for? What methods do you?
Jim, this is Lou Barnes. You didn't catch me on the roll call earlier. I'm the AATB representative. I'm a 35-year tissue bank career guy. In fact, I started my career with Scott Brubaker as one of my team leaders way back in the day. I have gray hair and he still has some. I just wanted to weigh in at the moment. Not all tissue banks are AATB accredited. That's a voluntary program. And for those who are new to it, many of us dedicated professionals have been committed to sharing best practices throughout our entire career at AATB, codified in a set of standards and an inspection process that happens every 3 years. At each of these sentinel events that have occurred over time, we've been quick to react and change and move to mitigate going forward the risk that is associated with tissue transplants. And it's a multifaceted approach. Tissue utilization records were implemented. Many AATB accredited banks get a high percentage return rate, but that so-called last mile, the compliance from the implanting facility, remains a challenge for us all to account for 100% of the tissues from donor through manufacturing to a recipient or through a disposition other than implantation. Testing, for those in the field who are aware, there are a handful of blood tests for those organisms in circulation that are certified and accredited by FDA for cadaveric specimens. Unfortunately, for tuberculosis, there's no blood testing that's available that is validated and approved to be implemented. What we've learned as a group of professionals is that may be a moonshot, but it's something we continue to dig into to try to better understand what we can put in place to minimize the risk. From a donor screening perspective, the association pulled together a work group through the Physicians Council at the association and issued a new set of guidance. That guidance also had input from FDA as it relates to the screening of donors for those viable cell allografts. We know that that is going to be an ongoing process and will continue to mature over time. And we also await FDA's issuance of new guidance related to communicable disease evaluation of donors. All this to say that we're very much engaged and involved in trying to mitigating the risk and have historically moved first and fastest. We understand the gap that currently exists, and we also find it unacceptable and will move to do what we can. And I look forward to the discussion about the last mile, if you will, from the manufacturer to the consignee and then on to the patient, that aspect, and discussions later in the day concerning labeling conventions for the tissue products that may or may not aid in that tracking endeavor. Thank you.
Thank you. I'd like to add an optimistic comment, and that is we now have the Blood Organ and Tissue Senior Executive Council, or BOTSEC, in place to address the ACBTSA recommendations, and Admiral Levine chairs the BOTSEC, and this was not in place in 2015. She is dedicated to this cause, so I'm hopeful. I'd like to also add my own personal comment, and that is we will always miss some diseases on screening. That's just the nature of tests and our inability to get the perfect test. However, so we may not be able to strengthen that aspect of things, but we can strengthen the review of the donor ahead of time. We can also strengthen the traceability. Those two things should help, and those are within our grasp.
We are a little ahead of schedule, so we are going to take a 10-minute break.
Cassandra.
Oh, I'm sorry. Cassandra, go ahead.
Since we are a little, I just wanted to mention one more thing that I think is really important that you touched on, but I think is bigger, and it goes to what we can strengthen, which is consent. And I know we don't have the denominator, and I know we don't have all of that, but when we had this problem that I was describing earlier, consent was a big deal because people were not getting consent or documenting consent, not consent in the way we give blood, right? Or in the way we do organ transplant. And I think that the lay public does not know, what we're talking about here, but implants for dental is huge. I mean, implants of bone, which they know probably the way you treat bone really matters about how well it works as a, graft. I just think that we could strengthen definitely and require that there is consent, informed consent from an ethical standpoint, because otherwise patients are unaware. We talk about doctors being unaware. Well, that's one thing, but it's not fair to the patient who we are recommending things to, that they don't have any clue that this could happen to them. Thank you.
Sridhar, excuse me. One of the big things that we can't really regulate and which has really confounded the subgroup has been the decision-making processes that go for us to choose which donor to actually pursue and which one not to pursue. In your highlight of the TB transmissions, you didn't say it, but you may as well have said these were probably not good donors. They had all the hallmarks of active infection, and with TB and weight loss and all the rest, and that maybe these shouldn't have been used. The way that we screen, however, we have the surveillance tool, but we ask people about the adequacy of the thing. You mentioned in there the proxy didn't know anything. Who was the proxy? How close is it? Should we have standards as to how well people know other people? It's one of the questions which comes through as to say, how accurate is the information that we get as to who does it? And then the subsequent release of processing the tissue that's been retrieved for it to go through the system is inside of, it's not standardized in a sense of how things work. And maybe you could mention for two different things. One is the decision-making as to what donors to pursue, and then how do we release tissue? Scott's going to talk, I think, a bit about that. A little bit, but as to what we have for regulations, but is that something that should be looked at and maybe enhanced?
I mean, I think that, in our experience with blood, organ, and tissue investigations over the years is that, there's inherent limitations even to living well donors, for example, blood donors who don't disclose their risk histories, even when explicitly asked, for example, did you get a yellow fever vaccination? And they say no, even though they did get one. Years ago, I think CDC's, the NCHS did a cognitive assessment of the blood donor history questionnaire. And that was specifically to look, for example, at donors who might not disclose MSM behavior at the time. And what they really learned was that a lot of people who present, not all, but a lot of people who present for blood donation seem to answer questions through the prism of they're asking me, is my blood safe? So for example, my blood is safe, I'm safe, so I'm just going to say no. Maybe they don't remember also. So, I think when you have limitations to the accuracy of donors who are alive and well and can talk to you, the idea that a proxy will know everything about a deceased donor, I think, is fairly far-fetched. We've had organ donor transmission events where, the family member who consented for organ donation did not disclose animal exposures, but on retrospective testing, it turned out that the donor hunted raccoons, trapped them, ate them, and so it's really, I think that to get around the issue of is a proxy going to know, even when they live with somebody, all the risk behaviors and disclose them in the context of a donation, there's just limitations to that. So I don't know if restrictions on how well did the proxy know this person, I think that that's going to be probably difficult to really tease out. And then the question of release of tissues, I think that's something Scott probably would be able to answer in his subsequent presentation.
But I think really the work groups discussed all this, and their recommendations of the gaps they identified are excellent. So
right.
It'll come out there as well.
Yeah.
Hi, it's Daniela Hermelin. I'm happy to be the newbie in the room and maybe thinking outside the box a little, asking ourselves if we were to create the process today, would we do it the same way? And it's kind of neat to be in a room of both individuals that collect blood and also tissue and transplant. So thinking ahead, would we be able to ask our donors who want to perhaps donate, once deceased, just like as we do our granulocyte donors, we try to select those that have a good donation history, that have infectious disease testing prior to actually collecting. So can we collaborate and pick out donors who could be great deceased donors, God forbid, but thinking about that. And because once upon a time, we looked at our blood donors, those that were altruistic and those that were paid, and we saw that that mattered. So our cadaveric donors, is there a different system in place of our live donors? And if we're able to, as Dr. Cohn, proactively be able to recruit donors that can possibly be safer, or our process be safer, is that a possible way forward? Thank you.
I think somebody had a comment on the, do we have time for the comment on the video? Like,
Go ahead.
Thank you. Yes, Elisa Gordon here. I just wanted to comment with regard to the informed consent process for potential transplant recipients with regard to being informed about the risks of infectious disease transmission. That is a part of the informed consent process. And just to frame this a little bit more in a historical context, I would say this is just rough, like from 2009 to 2020, the CDC high risk category had been prominent in the sense that potential organ transplant recipients had to sign a specific informed consent to receive one of the CDC high risk designated organs, donor organs. And but that has since, as of about 2020 or so, has since been diminished or removed, given the rates of such transmission have diminished or are so minimal. And so, it might be worth, maybe reconsidering, given the continued set of disease transmissions that continue to occur over recent years, to maintain more attention or place more attention to the informed consent process for potential recipients. Thank you.
Thank you. If there are no more questions, we will have questions again later. We're going to break for 10 minutes. So if we say we'll be back at 10:50, we'll meet up. We're a little chilly in here. Maybe everybody can get out and do some running in place. Thank you. We are back now. Our speaker will be Scott Brubaker. He will present on the regulatory oversight of tissue establishments and HCTPs. Thank you. Scott?
Thank you, Diane and Claudia, and I'm honored to be here to give this brief presentation. It's only 30 minutes long. I do want to say though that Michelle, when you made a comment that you're in a room full of doctors, I'm not a doctor. I'm also not a lawyer. But I do have experience in tissue banking, like Ann and I were just discussing a minute ago about we came from industry and went to FDA, and that doesn't happen that often. So we do bring experience, though, that's helpful, we believe. Okay, so regulatory oversight of tissue establishments and human cells, tissues, and cellular and tissue-based products. Tricky. Okay, so my presentation is going to focus on just a few requirements under the 21 CFR Part 1271 regulations And I picked these because they're related to biovigilance, and it includes information on HCTP reporting requirements, certain compliance actions, and experiences from the CBER's tissue safety team. I was director of the Division of Human Tissue, and one of those job functions is to chair the tissue safety team. So I'll talk a little bit about that and what some of our findings have been. So again, the presentation is not intended to provide a complete description of regulatory requirements for establishments that manufacture HCTPs. And there's also some blue font introduced that's not in the regulations. It's just there for emphasis, so you can focus on that bit. I know regulations can be kind of dry when they're presented, so I'll try to overcome that. So there are 40 definitions in the regulations. This is one of them. It applies because we're talking about HCTPs, but they are articles containing or consisting of human cells or tissues that are intended for implantation, transplantation, infusion, or transfer into a human recipient. So as I'm presenting this too, think about what you know, and there's a lot of experts here for blood and blood product and transfusion, and what the differences are. And even with differences with organ transplantation, think about the differences. So this regulatory definition does have some examples, such as bone, ligament, skin, and cornea, and as well as articles that are not under the regulations as oversight for HCTPs. Vascularized human organs for transplant, whole blood or blood components or blood derivative products, cells, tissues, and organs derived from non-human animals are also excluded. Now, I'll probably, since I have a little extra time, I'm going to spend a little bit of time on this slide. When an establishment registers with CBER as an HCTP establishment, there'll be these 28 types, HCTP types listed, and then they select, the manufacturing processes that they're involved in with each of the tissue types that they manufacture or handle. They're living donors and deceased donors. These tissues are derived from these different types of donors, which is, again, different than blood. You can see I've grouped some of the living donors into gestational, reproductive, and other. And deceased donors to tissues are all together. Now, when you think about the industry, say if you're thinking about the HCTP industry, it's actually got groups of stakeholders that don't talk to each other. They don't really communicate with each other. They follow the same regulations, but that's not like they're in a professional society or group altogether. That's not the case. If we look at how these are preserved, all these different types, fresh refrigerated, simply frozen, cryopreserved, or lyophilized. Now, there are some other variations to some of those with different types of preservation methods, but that's about it in general. If we just look at the establishments that manufacture gestational tissue, the folks who handle amniotic membrane aren't really going to communicate directly with those who handle cord blood. Now, the cord blood folks could be related to others like HPCA apheresis centers. They may actually, HPCA apheresis centers could be involved with a blood bank and a cord blood bank. But again, it depends on relationships and how that all works. If we look at the reproductive sector, I call them sectors. That's not an FDA term. I'll probably use some terms that FDA doesn't use, so I'm sorry about that. But the reproductive sector, they don't really communicate with anyone else in this, all of this list here. It just doesn't happen. We have skin banks, we have bone banks, multi-tissue banks, and eye banks. And do the eye banks and the tissue banks speak to each other? They do. They have relationships in areas, but as far as donor eligibility goes, they all follow FDA guidance and rules, but they don't really to get together to work out some things, and do have a new approach to something like MTB, for instance. Are they working together? It would be great if we could hear about that from speakers that will follow. And then the other point of this slide is to think about the end users and the diversity of the end users. So those who might use cord blood or apheresis, HPC, hematopoietic progenitor stem cell apheresis products, PBMCs, the peripheral blood mononuclear cells, they're going to be end users that are specific for those products, but they're not. There are other end users out there. If you think about amniotic membrane alone, wound care, there are wound care clinics, there are end users that specifically treat wounds. Amniotic membrane's used for that. But amniotic membrane can also be used for orthopedics, like in spinal surgery. It can be used to treat burns, but in the US that doesn't happen as often. But if you look at the embryologists that would use the reproductive tissues, okay, they're entirely separate from everyone else. If you look at blood vessels and heart valves or cardiac tissue non-valve products, they're used by cardiothoracic surgeons or vascular surgeons. If you look at bone, well, we've learned that dental procedures. I have bone in my mouth from a cadaver. It's cancellous bone product to rebuild that alveolar ridge to put an implant there. Very common. But bone can be used by orthopedic surgeons and all over the body, all parts of the body, and especially the spine. Cartilage is there, cornea. So the ophthalmologists, the professionals that implant corneas and use them, do they communicate with any other of the end users there? No, not really. And that's a specialty. So you expect that, that's going to happen. But I want to make sure you understand the diversity of the end user population of HCTPs. So how do you get them involved and get them to do things to correct some of these gaps is a challenge, but it can be done. I think there was a little bit of information about surveys that are done, and they're done periodically and not often. But we do know that bone is probably the one HCTP type that is distributed the most. So over 2 million a year is a good estimate. And amniotic membrane has now come up to about, I think the last survey result I saw was about 400,000. So the numbers are pretty high, but not for all of them. So when FDA started to have oversight of HCTPs, there were 2 regulatory tiers that were developed based on risk. And the first set is what we're talking about mostly here at this meeting, or what we call Section 361 HCTPs. So they're regulated solely under the authority of Sections 361 of the Public Health Service Act, and that addresses specifically the risk of communicable diseases and control of contamination and cross-contamination, that sort of thing. So if your product, and this is voluntarily applied by establishments, that you evaluate your products and do they meet all the criteria, and there are 4 of them in a regulation we refer to as 127110A. So I'm not going to go into this kind of detail, but that would involve, is it minimally manipulated? Is it intended for homologous use? Is it combined with another article during manufacture? Or does it rely on the metabolic activity of living cells for its primary function? So those are generally what those address. And if you look at your products and say, yes, I've evaluated them and they meet those 4 criteria, then you could be regulated solely under Section 361 and the regulations in 21 CFR Part 1271. No FDA review is done for those products. They can be marketed. Now, if you have a product that doesn't meet any one of those 4 criteria, then you would be regulated not only under Section 361, but also Section 351 of the Public Health Service Act and other applicable regulations you see there. And this would address the is your product intended to prevent, treat, or cure a disease or condition? So there's a different regulatory tier there. Safety, efficacy, et cetera, are some of the expectations. And if you just look at that safety word, the safety includes, for a product like this, includes what I'll show you is subpart C, donor eligibility requirements and regulations and associated guidance. And some of the current good tissue practice regulations are also applicable to a product like that. But these get pre-market review, such as investigational new drug application, a biologic license application, or a 510K pathway for devices. But the 1271 regulations still apply, like I just described in part. So this table just shows the subparts that are involved. I will be covering a little bit of the ones that are in bold here because they do directly have an influence on biovigilance. Now, these were implemented for HCTPs recovered on or after May 25, 2005. Now, this is very important that the scope of Part 1271 regulations are really involve establishments that manufacture HCTPs that are regulated solely under Section 361. And then, of course, we refer to 1271.10 that I just described to you. And then here's another definition, though. Manufacture means, but is not limited to, any or all steps in the recovery, processing, storage, labeling, packaging, or distribution of any human cell or tissue and the screening or testing of the cell or tissue donor. So if you're involved in any of those manufacturing steps, you have to follow applicable regulations in 1271. Exceptions from the requirements. So there are 6 of them, but I want to point out 2 because this is about end users. So you're not required to comply with the requirements of this part if you're an establishment that removes HCTPs from an individual and implants such HCTPs into the same individual during the same surgical procedure. Now, there's an accompanying guidance document that goes into details about this. It's autologous tissue reimplantation, basically. And then in 1271.15d, you're not required to comply with the regulations of this part if you are an establishment that does not recover, screen, test, process, label, package, or distribute, but only receives or stores the product solely for implantation, transplantation, infusion, or transfer within your facility. So that's going to be end users. We refer to them in regulations, and you'll see the word consignee, and that's how we refer to where that product is sent for use. So as part of the regulations, we do have, of course, that subpart C, donor eligibility, and I'll be covering some of that. The first regulation that appears is 127145, and it sets out requirements for determining donor eligibility. And this is actually a part of the good tissue practice regulations as well. They do dovetail together in that regard. But a donor eligibility determination based on donor screening and testing for relevant communicable disease agents and diseases is required for all donors of cells or tissues used in the product. I'm not going to talk about reproductive tissues any more than I just have, so I'm not going to go into those details. If I can say, the work groups that were formed within the subcommittee, we did not consider reproductive cells and tissues at all in all of the work that the work groups did in finding gaps. So that should be noted by you too, that we didn't really include them. So just like with blood donation, we have blood donation has relevant transfusion transmitted infections, and we have relevant communicable disease agents and diseases for HCTPs. So we call them RCDADs for short, so you'll hear that acronym a lot. But for all donors, when this was released, as a final rule in 2005, the RCDADs listed in the regulations are HIV types 1 and 2, hepatitis B virus, hepatitis C virus, human transmissible spongiform encephalopathies, including Creutzfeldt-Jakob disease and also variant CJD, and T. pallidum, the agent that causes syphilis. And then later in guidance, it was realized that there should be more RCDADs, and there was substantial evidence that they do meet the criteria. Then vaccinia virus, sepsis, and West Nile virus were added in 2007 via guidance from FDA. And there's a way in the regulations, if you look them up, it's 1271 3R2 that defines what qualifies, or, what factors qualify a new disease agent or disease to be included as a relevant disease agent or disease for HCTPs. Then we have another type of bucket, if you want to call it that, for viable leukocyte-rich cells and tissues. So it's a cell-associated disease, HTLV 1 and 2. And for reproductive cells and tissues, it's chlamydia and Neisseria, as you see there. Now, Zika virus was added back in 2016, if you recall, and what was going on that year. I remember coming to a meeting here that year, and we stayed at this hotel, but there was a huge CDC meeting with industries, not just the tissue and cell industry, but across the way at the CDC campus, and it was really highly attended to address what's happening with Zika in the US. But this year, it was realized now, 8 years later, it's not relevant any longer. It's not found in the population, the donor population. It's rare to see even importation after someone visits one of the risk areas and gets infected and comes back. So it was withdrawn as an RCDAD, and the guidance was withdrawn in May of this year. So this is just a snapshot for you of donor screening and testing on a table. You can see the RCDADs are there. There's also xenotransplantation risk is written into the regulations. It's not a disease or disease agent, but risks associated with xenotransplantation, there is a screening requirement for that. As well, CMV is not identified as an RCDAD. It's ubiquitous in the population. So there are instances where the clinician would want to know what that test result is for the donor of that product, because it may be important for their patient. So that's listed there as a testing requirement, but only for viable leukocyte-rich HCTPs, because it's a cell-associated disease. So I won't go through that list in more detail. Oh, yes, but some of these, as you'll see on the next slide, for some of these, the testing is not only serology, but also nucleic acid testing. So, there are some that will have more than one type of test to adequately and appropriately reduce the risk of transmission. So a molecular test and serology, you'll see it on the next slide where it's appropriate. So in the regulations, we require use of FDA licensed, cleared, or approved, I should say appropriate FDA licensed, cleared, or approved tests to test HCTP donors. So you'll see a number of these they're FDA licensed donor screening tests. That's actually part of the reg. And you can see there are a number of them that are licensed, and those similar tests or same tests are used for blood donation. Then we have cleared tests such as T-pallidum that they're cleared for donor screening. And then we'll have some that don't meet that definition, but they're FDA cleared diagnostic tests. So that's CT and NG there. But if you look at hepatitis B, there are 3 tests there: hepatitis B surface antigen, total antibody to hepatitis B core antigen, and the NAT test for HBV. So that's a good example of where you'll have molecular testing and serological testing that are required. And we have guidance documents to help with understanding these requirements for testing. And that's some of the updates that have been made by FDA since 2007 are those that are listed there for syphilis, West Nile virus, and HBV testing in 2015 and 2016. I was hoping I could give more information about these, but I can't. Unfortunately, they are in the clearance process at FDA. We put out, FDA issues a guidance agenda usually every January, and then either June or July, they'll update the guidance documents that they plan to try to issue in that fiscal year. So these are listed. It was updated in July. The January agenda only had 3 here. It was the first 2 and the last one. And then when we updated it in July, we're pretty close to getting 3 more issued with really updates that have been pending since 2007 when you think about it. So there's a lot of work being done. You can see Mycobacterium tuberculosis is there. Disease agents associated with sepsis is there. HIV, HBV, and HCV. And what we call, it's gone through a couple of different names internally, like the parent guidance, the mother guidance. We think we ended up with the general guidance. That's the one from 2007 that's being updated now. And it'll look different. It looks a little different, but I can't say too much more than that right now. But you can see this and track it, but hopefully they will be issued soon. So looking at biovigilance more in the regulations, if you see the donor eligibility subpart C section, that's where it first describes a distinct identification code must be used. And then what you'll see later is that in current good tissue practice regulations, that's where we say a lot more about the distinct identification code. But in donor eligibility, once that donor eligibility determination has been made, the following must accompany the HCTP at all times. And you can see a distinct ID code is affixed to the container. And that distinct identification code, we just refer to it as it can be alphanumeric because many of them are. And then when we go to the good tissue practice regulations, labeling, 1271-370 labeling requires you must label them, each HCTP made available for distribution clearly and accurately, and the information must include a distinct identification code that's affixed to the container. So it's addressed again, and it's going to be addressed again. So, there could be no missing this requirement. Actually, there's an entire paragraph, a couple of paragraphs here in section 290 for tracking. It says if you perform any step in the manufacture of an HCTP, you must handle the product in which you handle the product. You must track each product in accordance with this section to facilitate the investigation of actual or suspected transmission of communicable disease and take appropriate and timely corrective action. So that is built into the regulations to take these steps. And we're seeing that those steps do work and that establishments are following them. Also, you must establish and maintain a system of HCTP tracking that enables tracking of HCTPs from the donor to the consignee or final disposition, because we've seen in Streeter's talk, they can be discarded either by the manufacturer or by the end user. And it should go back, the consignee or final disposition to the donor. So the establishments are required to have that system in place. And as part of the tracking and the distinct identification code and part of your tracking system, you must ensure that each product you manufacture is assigned and labeled with the distinct identification code that relates the product to the donor and to all records pertaining to the product. And that labeling includes information designed to facilitate effective tracking using the distinct identification code from the donor to the recipient, from the recipient to the donor. You can adopt someone else's system of coding, but if you assign a new code to an HCTP, you must establish and maintain procedures for relating the new code to the old code. And that happens. The recovery program or acquisition partner may have their own tracking system they use internally, their own distinct identification code. And then when they send it to another manufacturer for processing, they have their own system. But the idea is that you can track and actually link those numbers whenever it's necessary, which is really all the time when you think about it, not just when there's a recall or a problem. Records all have the double numbers there. The numbers can expand and be more than 2. But there is an expectation that that association can be made. Also under tracking from the consignee to the donor, you must establish and maintain a method for recording the distinct identification code and the type of each product distributed to a consignee. And here it is, tracking from the donor to consignee or final disposition. Then you must establish and maintain a method for documenting the disposition of each of your products to enable tracking again to the consignee or final disposition. And this information you maintain must permit the prompt identification of the consignee of the HCTP, if any. Now, I did work in industry for 30 years before coming to FDA, and we looked at recall events, I guess, that happened over the years. And the tissue banks could always track to the consignee all the time. But as Streeter pointed out, from that point on, and actually Diane Wilson and I co-authored an article that explained this, it was usually between, I think, 5 and 9% of the tissue products. And about, I think, do we have 5 or 6 recall events, experiences? It was 5 to 9% could not be located and tracked to recipients by consignees. So this is important too. It doesn't stay within the tissue establishment, but at or before the time of distribution of a product to a consignee, you must inform the consignee in writing of the requirements of this section for tracking and of the tracking system that you have established and that you maintain to comply with requirements. Instructions for use. That's the kind of document where this information is relayed to end users. So it's not only how to prepare the product for use, but also tells them about the tracking system and what they expect. And I've seen various versions of IFUs while being at FDA and even before that, and most of them do have pretty good detail, a nice paragraph about tracking. Now here's another definition that will help you to understand the following slides. An HCTP deviation. It means an event that represents a deviation from applicable regulations in all of Part 1271, or from applicable standards or established specifications that relate to the prevention of communicable disease transmission or product contamination. Or it could be an unexpected or unforeseeable event that may relate to the transmission or potential transmission of a communicable disease or may lead to product contamination. So things will happen because we're human, errors happen, and then you only find out later after the product is distributed. My gosh, we didn't know this, we didn't realize it, and then you have to act upon that. But it's called a deviation. So deviations, where they're realized, in that case, must be reported to FDA. You must, and the regulations describe that you must investigate all product deviations related to a distributed HCTP, and you must report them within 45 days of the discovery of the event. Report them to CBER using an electronic system. And also, the information on any follow-up actions that have been or will be taken in response to the deviation, such as a recall, that needs to be, FDA needs to be updated about progress there. And sometimes you can, in a 45-day period, all of that will have taken place already, and all of that is reported to FDA. The Office of Compliance and Biologics Quality handles those, OCBQ at FDA, as CBER. So this information is from OCBQ, but you can see numbers. There's between 2 and 250 pretty much every year. You always see a dip in the pandemic year, if we want to call it 1 year, is 2020, but you can see that they do happen. A lot of them are cellular HCTPs, but HPC, apheresis, for example. But those products are life-saving. There can be contamination from a culture. The urgent medical need provision is used because they have to be used for that patient. And we don't see a lot of infection reports, though, come back. You'll see that on another slide when they're used. It's really interesting. But you can see the 95 are tissue products. 33 of those situations were potential for recalls. The most frequent deviations involved include receipt, pre-distribution, shipment, and distribution, which is more of that. There's some related to processing in there. Then there's donor screening, 18, 16 donor testing, and 14 involved donor eligibility. So errors are made. And these are the ones that were recognized and reported. If the recall occurs, then they're classified by FDA. It may take some time to classify as 1, 2, or 3. I think everyone understands how 1 is the most serious situation that is likely to cause transmission of disease. But in last year, the numbers showed 27 class 2 recalls, 3 class 3, for a total of 30, and you can see how it's broken down there. But I thought it would be interesting to also include those 27 involved deviations involving plasma dilution, evaluation of the sample used for testing, the donor sample, RCDAD test results. There could be processing deviations that were recognized after distribution, And also donor eligibility determination was not made correctly. And then class 3, other test results. Sometimes, like in that case, you'll have a test result that was found to be maybe invalid. And then the donor testing was done later after the deviation was realized, and it was retested and found to be negative under a valid report. So, you know, then the risk is less because the donor, it's been investigated and found to be not a risk for recipients. That's just one example. So this regulation in 21 CFR Part 7 under enforcement policy in subpart C, and I won't read that whole title, but this is applicable to HCTP establishments. It's not in the 1271 regulations, but it's in another part of the regulations, and recall policy, and I will read this because it's important. Recall is an effective method of removing or correcting consumer products that are in violation of laws administered by the FDA. Recall is a voluntary action that takes place because manufacturers and distributors carry out their responsibility to protect the public health and well-being from products that present a risk of injury or are otherwise defective. Now, it was described to me that FDA's robust recall program includes regulations, and there's a footnote there, and procedures to verify that the responsible firm has conducted effectiveness checks to determine that consignees receive notification about recalls and the consignee has taken appropriate action. So in our investigations and inspections, you know, this is something that they do look at. The field investigators do focus on this. Now, when a deviation is, this is an example, when a deviation is not reported to FDA, but it's found that the deviation occurred when they're being inspected. So it's going to be a citation, an observation on a report from of the inspection. But if the firm doesn't respond effectively to those citations, they might get a warning letter. And here's two examples just from this year in June, where the deviations were identified that the IBanks failed to determine as ineligible 5 donors of ocular products with a documented diagnosis of clinical evidence of sepsis. And you can see the other one is 2 donors. So this is the tip of the iceberg, so to speak, because the field investigators only have so much time, and there are hundreds of donors, eye donors, or even any donor, any tissue donor, at firms like this that they inspect. But again, the response to the observations was insufficient, and it resulted in a warning letter that you must change policies and procedures. So another part of the reporting requirements is to report adverse reactions, and there's a definition here for that. It means a noxious or unintended response to any product for which there is a reasonable possibility that the HCTP caused the response. So here's the reporting. You must investigate any adverse reaction, and sometimes these are found in complaint files. That's what the establishment where they might actually put those. Involving a communicable disease related to the product that you made available for distribution. You must report to FDA an adverse reaction involving a communicable disease if it's fatal, life-threatening, results in permanent impairment of a body function or permanent damage to body structure, or necessitates medical or surgical intervention, including hospitalization. You submit it on a specific form, and it must be done within 15 calendar days of initial receipt of the information. Now I go back here because this reasonable possibility statement, the establishment has within that 15 days, they determine whether there is a reasonable possibility. If they determine there is not, then it doesn't get reported to FDA. So also it says in this requirement that you must, as soon as practical, investigate all adverse reactions, and you must submit follow-up reports within 15 calendar days of receipt of new information. And we do see this happening. I'm going to describe the tissue safety team's work, and we do see that firms are doing this. If additional information is not obtainable, a follow-up report may be required that describes briefly what steps you took to seek additional information and the reasons why it could not be obtained. And I'm going to relay some of that information too. So CBER has a tissue safety team. It has interdisciplinary membership across CBER offices, the Office of Biostatistics and Pharmacovigilance, the Office of Compliance and Biologics Quality, the super office where my sub-office is located, the Office of Therapeutic Products. And where applicable, we'll get the CBER Office of the Director involved, and also the Office of Communications and Outreach Development in case there is an outbreak. So this is a coordinated approach for handling only 361 HCTP adverse reaction reports. It's required by the manufacturer, and they use form FDA 3500A. But direct reports can be made from end users and consignees. It would be voluntary, and they use form FDA 3500. Now, we conduct follow-up reports involving the infections, and we work with the manufacturers to investigate the results of actually look at their investigation. We routinely request donor screening and testing information, tissue culture reports, tissue processing information. If there were any deviations that were related to the adverse reaction report, and we might request all donor records, and we've been doing that more in the past year and a half, and have found septic donors were being determined eligible when we looked closely at the records. We do ask the direct reporter to the tissue bank normally and sometimes to FDA about culture reports. We'd like to see those of the patient that's affected, clinical course, symptoms, outcomes, and what is the distinct identification code or codes, because more than one product can be given to a recipient that could be involved in this investigation. And I'll show you that that we don't get good results there. We have bi-weekly meetings. They're 1 hour long and they're packed. See, I've been the chair of the TST for 8 years. I guess it's really interesting to me that this happens. I'm sorry to get upset, but if folks aren't made to do something, they're probably not going to do it. That's really what it comes down to. And when I was at AATB, we made sure membership was aware of this too, that, if somebody is not cooperating with you, a consignee, an end user, they're not sending information, because sometimes they would get this, hand in the face. It's like, no, HIPAA doesn't allow me to do that. Well, yes, it does, actually. The HIPAA privacy rule is not intended to disrupt or discourage adverse event reporting in any way. The rule specifically permits covered entities to report adverse events and other information related to quality, effectiveness, and safety, and this includes pharmacists, physicians, and hospitals. So covered entities, like I said, they can report to FDA directly or to the manufacturer. The manufacturer will get on it immediately, so you're going to save time if you report directly to the manufacturer, but you can also report to both. That's possible. And then the folks that end users should make effort to submit the minimum protected information necessary for report. So here is experience from the tissue safety team since 2018, just summarized. We do get reports that are not infectious or related to communicable diseases. So you can see that in, we just look at 2023, there were 181. 152 of those were involved communicable disease or potential communicable disease transmission. And when there was a match, this is what we really look for, a match between any culture's pre-processing or processing that are matched with the recipient infection. So if we don't have half of that information, we're not going to be able to match them. That we could match 40 is, again, tip of the iceberg. It's just, those are the ones that we were able to match them. Some products out there, they don't even have a recovery culture done or a processing culture done related to processing. And then we have an obvious infection that we've seen over and over again in a recipient, say a cornea as an example. But there can be no relationship made to the donor or the tissue. You can see this is what I was talking about for HPCs. They don't have many infections, although you've seen all those deviations that they report. So the transmissions aren't happening when there's a bacterial, contamination. And then in 2023, if you look at that, 40 out of 152, that's 26.3% involved matches. But the reality is probably higher than that if we had all of the information necessary. So for tissues only, this goes back again to 2018, across the board by tissue type. You can see every year either skin, bone, or eye tissue are usually the top three involved in all of the reports that we do receive. Now I highlighted 40 there with an asterisk. I presented the table at the Eye Bank Association of America meeting this year, and I just wanted to point out to them that they have a system and in their standards, their medical standards, where the medical director must evaluate an adverse reaction, and then the imputability grading is applied to it. Unlikely, likely, probable, definite, that sort of thing, that sort of grading. And we've been tracking those because we're very interested, because sometimes they'll say it's probably due to the cornea tissue, and we're like, we don't have any information that tells us that. We don't have the match, but they determine that there is that potential. So their medical directors, for that 40, 30 of them were definite, likely, or possible. 30 out of 40, so that's 75%. I don't believe that we don't receive those types of imputability gradings from anyone else but the Eye Bank. So I'll hurry a little bit. Infectious disease reports just put on a pie chart, as you can see, for last year was bone, skin, then eye tissue. I talked about the reporter tissue type. A reporter type for the tissue, and you can see most of it is from manufacturers. Few are from end users, though. And then part of the requirements and the regulations are to establish the maintenance of a quality program, and the functions here talk to including complaints that the quality program has to handle, have a system for handling complaints, sharing information pertaining to possible contamination of the product or the potential for transmission of a communicable disease by the product. They share it with other establishments known to have recovered the product from the same donor, other establishments that are known to have performed manufacturing steps, And relating to consignees, procedures must include provisions for assessing risk and appropriate follow-up, and for evaluating the effect this information has on the product, and for the notification of all entities to whom the affected product was distributed. And that could include, of course, quarantine and recall, and reporting to FDA. So just in summary, there are a variety of HCTP types manufactured by multiple cell and tissue stakeholders. Even more so, the end users are a diverse group throughout that whole spectrum. The scope of the regulations in Part 1271 apply to manufacturers of products. Our regulatory authority is based on risk of communicable disease transmission. The regulations require a distinct identification code and prompt tracking to consignees. And by our effectiveness checks during recalls, it confirms the ability of manufacturers to track products as expected. Deviations and adverse reaction reporting to FDA, investigation and follow-up is required. FDA tracks the reports as well as recalls and checks compliance by manufacturers. And our experience identifies a lack of cooperation from hospitals and end user physicians who are covered entities under the HIPAA privacy rule when investigating an adverse reaction involving a product and a recipient infection. Often necessary information is not reported or not provided in reports or with follow-up, even with multiple contacts being made. And there are some resources there for you if you care to look at those. Thank you.
Thank you very much, Scott. We will hold questions until later in the afternoon. Our next speaker will be virtual is Owen McGrath. He is the Executive Director of ICCBBA ICBA, who will give us a public comment.
Thank you, Chair, and thank you to the committee for this opportunity to provide input to these proceedings. I'm assuming you can hear me okay, is that right? Okay. So as previously described in detail, traceability across the tissue pathway is challenging due to the potentially high number of products from a single donation event and the involvement of multiple actors in collection, processing, distribution, and their clinical application. And of course, these recent tissue-borne disease transmissions have highlighted what is clearly a persistent traceability gap. Given that a single donation event can involve multiple products and different actors, we do see that tissue processors are managing traceability effectively. However, the challenges seem to arise at the diverse collection and clinical administration points. The ISBT 128 standard addresses these issues through globally unique donation identification, internationally harmonized terminology, and encoding attributes related to, among other aspects, the content, safety, processing, and including infectious disease testing results. This provides detailed information to healthcare providers and patients. Standardized coding also supports the interoperability of electronic health information, facilitating data exchange across health information systems. ICBA, a nonprofit established in 1994, develops and manages the ISBT 128 standard. Initially developed for blood, the standard has since been extended to multiple MPHO, including tissues, cellular therapy, and ocular products. ICBA actively collaborates with stakeholders to enhance the standard and promote its adoption globally. Today, over 3,000 organizations in 75 countries are registered with ICBA, and ISBT 128 is required or endorsed by regulators and accreditation bodies in countries around the world. Complexity increases risk. Risk can be mitigated by implementing a globally unique donation event identifier, standardized product codes, including for those attributes critical for safety, and consistent terminology throughout the MPHO life cycle. These measures would significantly improve traceability and biovigilance efforts. The ISBT 128 standard is well positioned to meet this need, as recommended by this advisory committee's recommendations in 2015. We are convinced that standardization is a critical part of the solution and will energetically engage with stakeholders to enhance transplantation safety and efficiency. Thank you.
Thank you very much for the comments. Okay, we will now break for lunch.
Produced by the U.S. Department of Health and Human Services.